We are live now, and welcome to another episode of the Machine Medicine interview series on neuromodulation. And we're delighted this week to have Professor Leigh Charvet and Dr. Giuseppina Pilloni from New York with us here today. Welcome, both of you. And I wonder, perhaps we could start with you, Giuseppina. Could you give us a brief overview of how you got into this fascinating field? And yeah, I'm delighted to have you here. Can you hear us, Giuseppina? Maybe not. Okay. So perhaps we'll start with you, Leigh, if that's all right. And Giuseppina, well, Giuseppina's sorting out her sound issues.
Yeah.
Would you mind giving us a little overview of how you got into this area?
Yeah, sure. Giuseppina, are you on?
Yeah, I'm on.
Okay, so you can start with your background. So.
Okay, yeah, okay. So, but I cannot hear the other people.
Oh, okay.
I can see you, but like I cannot see the other people, and I cannot hear the other people.
Are you in the same building?
Yes.
Giuseppina?
Yeah.
Would it be all right if you went down the corridor, Giuseppina,
Okay,
and you both sat beside one another? I think rather than finding a technical solution, that might be.
Yeah. So yeah.
Yeah, maybe you would start, Leigh.
Yeah, I can start talking. So I'm a neuropsychologist, clinician, and I've worked in neurology, primarily with people living with multiple sclerosis or MS, but really all different types of neurologic conditions with cognitive and psychiatric problems resulting from their conditions. And so, and I've done a lot of research around that, and always with the research focus on what we can do, tools to improve quality of life and reduce the disease burden that they have. And so I did a large trial of cognitive remediation with people living with MS, and that trial was telemedicine, and that actually brought me into the world of TDCS because we were very interested to see if we could pair stimulation in the rehab setting to see if we could boost benefit of cognitive training to help get greater benefit in shorter amounts of time. And so that was about 8-9 years ago that I started partnering with biomedical engineers and immediately, because of my background in telerehabilitation, took TDCS at home for clinical application. And that's, directed the journey. That's been quite an intense journey bringing us to this part.
Got you, but so you really came to it from a very clinical kind of
place,
yeah,
absolutely,
but with a significant sort of tech element.
Yeah.
And Giuseppina, it'd be interesting to hear how you got into this, what your general background is, and how you got into this area.
So I'm a biomedical engineer, and I started working with Dr. Charvet since 2018. I went here in New York the first time from Cagliari in Italy. As a visiting PhD student, and then I joined the team last year. And so my main focus was during the PhD was like the quantitative assessment of gait and balance with inertial sensor and force platform. And so I apply this technology to see if some rehabilitative intervention can improve gait and balance in neurological disorder and specifically in multiple sclerosis.
Got you. So yeah, it's this kind of nice asymmetry. So you came to this field from really a very different place. I suspect several years ago you were studying systems of partial differential equations. And that kind of thing, right? And now you guys are working together, so that's fantastic. And that's, without further ado, it'd be great to sort of get on to the meat of your this recent publication on the use of transcranial electrical brain stimulation to manage the acute and the chronic COVID-19 symptoms. So I think as I mentioned briefly, Leigh, when we were talking before, I think it comes as a surprise to people to learn that neuromodulation and bioelectrical medicine more generally has a role in inflammatory disease, but it really does, and it could potentially be very impactful indeed, right? Is this, what's the best way to sort of think about it?
I think absolutely. And I think it's also driven by the accessibility, safety, and tolerability of these tools. So it's a non-drug intervention that patients can have immediately. It can be applied anywhere. And, you know, as we just mentioned, our focus is on home use. And so and if you look at the growing literature, there's a lot of potential direction that can go for evaluation and potential application of these stimulation therapies in managing COVID throughout its, you know, from acute infection through, you know, persistent symptoms and recovery.
But if I can play devil's advocate for a moment, I think, you know, certainly when I was studying neuroscience, I think the kind, or even medical science more generally, I think the way that we sort of conceived of the nervous system was as an information processing system. And in that regard, sort of certainly conceptually seemed to sort of consider the immune system and other sort of related systems, say the endocrine system, as somewhat sort of in parallel, but sort of separate. And yet there seems to be a premise underlying here that actually by intervening with, you know, electrical kind of interventions, we can actually modulate the immune system sort of, I guess, indirectly through the nervous system. Or
so indirectly is key. So we're not saying that this treats COVID. I think that it treats the effects of COVID on the system and manages, you know, the sequelae of what COVID does to somebody. And I think that what it does in the acute infection and the persisting symptoms is really unknown and still being characterized. And so it's just catching up to seeing if we can apply some of what we know in other syndromes and other situations to be of help here and to evaluate. But again, we have to remind ourselves too that this is an accessible, tolerable, safe, therapeutic approach. And so really, you know, a call for research, a call for evaluation, you know, and that's really the point of our paper too, is just for it to be considered fitting in really in an area we don't have many other therapeutic options right now.
Yeah, no, it's a great point, isn't it? Because, you know, drugs are sort of go-to as clinicians, and I do remember as a junior doctor myself the kind of sense of terror that it induced in me, just how common prescribing errors and sort of, you know, maybe even ignorance of what the effects of drugs, how much of that there was. And yet they were our kind of main tool, at least as physicians, for treating disease. And yet, you know, it was anaphylaxis and all kinds of unpleasant side effects and so forth. So they really are very dangerous things, right? Drugs. So this doesn't. So are there any deleterious effects? I mean, one would have thought that the power to do good would imply the power to do harm, and yet it doesn't seem very easy to actually damage people with these technologies. What's the underlying intuition for that?
Yeah, so I you know, especially with transcranial electrical stimulation, it comes from just a really strong record of safety and tolerability. There's been no serious adverse events reported in clinical trials to date. Certainly in our high volume of experience, it's really well tolerated. And so, you know, everything has side effects as far as, but they're usually, you know, at the site of the electrode, you know, discomfort, that kind of thing. That's not something that would prevent you from concern for evaluating in a therapeutic context. And we've, you know, but we're learning more and more, and we definitely need more evidence for sustained continued use of these therapeutics. You know, a lot of the trials have been really limited to few applications. And so if we look at, we really believe that there's a cumulative benefit. So you need repeat, ideally daily application for that benefit, extended periods of time. And we just don't have the full body of evidence that we need to really guide dosing parameters and what we would expect for long-term use. But with that, there's nothing yet that would make us think that or anticipate a worry about continued use. So so we're cautiously moving forward, but I do want to, you know, always note that there's caution and that more evidence is really needed, especially for dosing guidance and parameters in this field. Yeah,
no, absolutely. I mean, there's while the empirical, it seems to be quite a lot of encouraging empirical evidence that this stuff works and works quite well in contexts like COVID and actually, you know, many different aspects of the disease, right? You discuss in your paper the fact that it seems to be, it can be used in the early stages when there's an acute inflammatory response. It can also apparently help with supporting respiration through vagal nerve stimulation. Can also help with neuralgia, the pains that are chronic pain syndromes that may be associated with sort of long COVID, if indeed that exists, beyond a psychiatric phenomenon. But so it's a very, very powerful, but so much ignorance too, right? Like you said, we don't really know how this stuff is being affected. And I guess that's an interesting point for you, Giuseppina, if I may. What are the sort of interesting problems that attract an engineer and someone with your sort of skills and background to this area?
So there is a lot of technical thing in transcranial direct current stimulation, and especially all the modeling of electric field. So how the electric field is propagate in the brain, and this means which is the best target area to reach the best, the optimal benefit from this treatment. How the brain activation change with current intensity. So we should increase the current intensity, or we should use the standard 2.1 milliamp, for example. How long the treatment has to be. So 20 minutes, or we can increase. So there is a lot of like unknown things that we are like actually investigating, and also, for example, the real time effect of TDCS on our brain with like TDCS and MRI protocol, and so there is a lot of like
I mean, I guess there's a lot of different sort of levels of analysis that you can look at. Like you said, you can model the current, the current, and I guess that would be helpful for things like building systems that could predictively target a particular, say, deep nuclei in the brain, or indeed a superficial module of the brain. But then I also guess that there's you can model the sort of interaction of population of neurons with those currents from a sort of electrophysiological perspective. But then I guess at a deeper level, there does seem to be this sort of question of a neural code, right? Like somehow we're reprogramming nervous systems, which are then in turn reprogramming, remodulating inflammatory systems, or even cardiovascular or respiratory systems. And I guess it comes back to this sort of question that we had. It does seem to be something of a paradox that when you sort of intervene, although we have very little idea what we're actually saying in the neural code, it almost always seems to be either have no effect or to be beneficial. Does that strike you guys as curious? It strikes me as very curious indeed.
So I guess just building on what Giuseppina was saying is that, I was noting that we need dosing parameters from the clinical perspective, but we, as with many, we're not unique in this field, but mechanism remains largely unknown as well. And so we really need the work to understand, especially when we use it to target, to match what we think is a model of an illness and how that's affecting us. And we need to understand mechanistically to drive how we would use these. And so again, right now, where it's theoretical mechanism, or built on use and symptomatic use in other trials, or rehabilitative use in other trials, and bridging that to potential use in COVID. But I think that with the work and exactly what you're saying, as far as modulating neural code, influencing the neuroimmune response. Those are largely theoretical right now, and we really need imaging models and markers. Giuseppina's done we have a simultaneous TDCS MRI study going on, modeling the effects of TDCS application in real time and with the effects in the brain, and then looking at the consecutively applied results to that, so to see how it changes the brain. But all of that is so preliminary, and so I think that I just want to point out that we're in the theoretical kind of matching of disease to disease.
Sure. I guess, what do they say? Like in theory and practice should be the same, but in practice they're not.
No, right. Yeah.
But that's very interesting. So I guess another interesting aspect is what are the other kind of complement? I mean, you mentioned yourself, Leigh, that you actually had a bit of a background in telehealth as
Yeah,
well,
right.
even prior to getting into neuromodulation. And so there's a very sort of, what do you think the most sort of complementary kind of subsets of technologies are? I mean, I think in your paper you discussed the possibility of doing remote neuro rehabilitation, which is augmented by transcranial electrical stimulation. So a very kind of like cool sort of nexus of technologies delivering a therapy remotely, at scale. Right.
Yeah, so right, and that's how we actually started with TDCS, because of the handheld portability of the devices and telemedicine. And we know from almost every rehabilitative therapy, you need consecutive near daily application for extended periods of time. And so TDCS can be TES can be therapeutic on its own for certain uses, but also you can pair it to boost the learning that occurs with a simultaneous learning activity, whether it's physical or cognitive rehabilitation, for instance. And so with that angle, especially home-based therapy is really important to provide the ongoing daily sessions. We do it remotely supervised through telehealth, so it's very structured, very guided, but the technology is sent to patients at home and they're guided through it in that way. And so we had actually developed a whole system for that, 8 years of development to be able to reach patients in their homes to deliver TDCS for that purpose.
Right.
And we with COVID, again, especially that we suddenly were moved to telemedicine across the board. Patients were isolated in need of treatment. So it really lends itself well to that model to both reach patients in need and also to provide that ongoing daily type of therapeutic activity to boost recovery.
Gotcha. So that kind of, yes, is that how you decided to do this work in COVID? Just because, well, it's obviously very topical at the moment. Obviously a lot of people that have the condition and are suffering from the sequelae.
Yeah. So it's a very, major topic of just because everybody's trying to think of what can we do therapeutically to help all of the patients with COVID, and particularly with, we see a lot of people who have those persisting symptoms. We work with patients with neurologic disorders who then get COVID. So there's just a tremendous therapeutic need across the board. And so, it was positioned in that way. But also we have through NYU Langone here, we have an innovative care policy that allows us, so it's not approved here in the United States, but it's considered innovative care. So we have a clinical service where we provide tele-TDCS to patients in their homes therapeutically or clinically. And so we began to get people recovering from COVID in that service as well. And so that's kind of informed a lot of our thought, trying to optimize their rehabilitation, their recovery, and to help them in that way.
And so when you're doing a sort of tele session, why can't it be done asynchronously? Do you have to guide is it the positioning of the device that you have to guide? Why do you have to be?
Yeah, so you don't. We come from, our primary activity here is research. And so with all the rigor of research, and also from the abundance of caution, again, as you noted earlier, so these are patients often with a high level of neurologic impairment who are self-administering TDCS in their homes, and it can be complicated. There's technology involved. And so we built a system around live video connection at every point. And it's especially important if we're pairing it with an ongoing therapeutic activity. We can just really enable that. And so it's not necessary, I wouldn't say. And I think there is definitely technology and models where people can self-administer. I do think, though, that especially in the beginning, it lends itself really well to a daily contact therapeutic model, and that both for safety and clearance checks, but also just to checking in, reaching a patient at home every day is very powerful, and can also ensure adherence to the therapy and make sure everything's going okay. So there's a lot of kind of soft therapeutic benefits around that daily connection model too.
Gotcha. Yeah, okay. But if you're thinking about making it sort of truly very scalable, then
right, absolutely.
And if the technology were sort of suitably productized, I guess, and made very easy.
The technology here now for self-administration or for asynchronous administration, as you said, which can still be clinician guided at a lower level than live video connection. And I definitely think that that's where we're going. But again, we need that guided use, and
Yeah.
And it always want to come from an abundance of safety precaution that,
Mhm.
especially we're in somebody's home for their use. So.
Sure. So another interesting aspect of we often think about, and I'd be interested to hear your thoughts on it, because obviously one of the advantages of this is it's non-invasive. But then one of the interesting things that has happened in invasive neuromodulation, for example, in deep brain stimulation, is that you can now record at the same time as stimulating, and there's a lot of excitement, although not a lot of proof, I have to say, yet, but one hopes. A lot of excitement about being able to record simultaneously and use that signal as a feedback signal in order to optimize the as it were the forward stimulation, if you see what I mean. And so what kind of paradigms do you have in non-invasive this non-invasive context for getting a feedback signal to tell you, maybe as a teaching signal, as it were, to update your parameters ultimately, or even tell you if you're having any effect?
I can tell you that's a very topical question. That's a great question. We think about that a lot. Do you want to?
So we were thinking to use to monitor real-time rate variability, because can be used like as a biofeedback for to see if really there is like a change and an answer from your body to this kind of like.
So what was the metric you were measuring? The heart rate variability, or
the heart rate variability?
Right. So the interbeat variability. So the entropy of this sort of this interval. Is that right? That's interestingly sort of the entropy is sort of correlated with health, right?
Right. Exactly.
In a sort of broad kind of way that
Right.
And then as people get sort of more, as they get closer to death, I suppose.
So biomarker feedback as Giuseppina is really important. And so far, EEG has not been helpful for us to inform it. So that was probably the first go-to, and so we're looking at other things that we can simultaneously acquire that would inform both the treatment response, verification of treatment response, help us predict individual differences, and somehow mark response other than symptomatic reporting. I think it's really, really important, and right now we're just not there. But I think that the technology is going to enable us to be, even right now, when we're at home with devices, we can collect a lot of data on patients. So there's a lot of potential, but I don't think it's there yet. But
right, but you looked at heart rate variability. Did I understand correctly? But it didn't seem to really give you.
No, I was saying EEG. It was our kind of the first simultaneous.
EEG. Sorry, yeah. And that didn't really give you the answers that you wanted, and so now you're looking at more, I guess, less neurological ones, or more general kind of.
As a first step, yeah. So just things that we can collect, and we can definitely collect vitals and monitor vitals in real time through the devices. And so, but that's definitely an area of great potential, because these, with technology enabling ongoing biometric data collection, there's lots and lots of, ways that we can collect. And I think, to your point, that's going to be a very powerful tool in the end for optimization of how we use these tools.
Yeah. So just to sort of be clear about what you think is kind of not there yet, because there's a lot of Fitbits and various even medical grade kind of equipment, hardware that can be attached to people. The Apple Watch now has a whole health kit kind of software development kit attached to it. But are you really talking about the ability to simultaneously capture data across multiple hardware devices, and also to integrate that data in a clinically usable way? Is that the kind of...
And specifically in response to the use for TES therapeutics. So that across studies, across uses, it was definitely our experience. There's a lot of individual differences in responses.
Yeah.
And especially bringing it back to COVID, if you look, COVID, especially post-COVID, is multisystemic, right? So there's a lot. So what indicator can help us with the patient in real life? And so that's what always drives us is the clinical challenge and what we can do. So that was, so we're trying to think of ways, and you're right that there's a lot of technology. In some ways, though, there's no clear path to exactly what technology is going to be useful. Sometimes the complexity and the availability of the technology makes it harder to move forward. So we think about that a lot. And I think that soon that will be really part of the use of these kind of therapeutics for sure.
Yeah, I see. So the people that are developing the devices are generally not kind of developing these additional tools for the kind of, if we can call it kind of, obviously there's kind of device data where you sort of set stimulation.
I think the next step, I think there's a lot of interesting device designs coming down. And I also think that the devices may be able to also deliver digital health therapeutics. So pairing the stimulation, so we believe very much that ongoing therapeutic activity, training, rehab, with the stimulation boosts that benefit, potentiates the benefit. And so if the device can deliver the digital therapeutics, I think there's a lot of interest, early development in pairing the digital health therapeutics with the stimulation therapies as well.
Yeah, I see what you mean. Yeah, because there's a sort of synergy between them, and if you can do that all in one fell swoop, that would be. And Giuseppina, from your view, from your perspective, what are the main technical challenges for the next sort of few years, say 5 to 10 years, as a biomedical engineer?
As a biomedical engineer, for sure, being able to more specific in the stimulation of the target and of the brain target. So because of course we are using some electrode montage that are standard, but on standard measure, but of course there's a lot of difference between patients. And so I think the next step will be reduce this variability between subjects.
Yeah.
And this maybe will get a better result in terms of uniformity of response to them.
So what we really need ultimately, right, is a kind of digital twin, a digital double of the patient, right, that we can perform in silico sort of experiments on and work out what the best sort of location and protocol would be for that individual, right? But that's no mean feat. But I guess are these primarily software innovations then we're talking about rather than hardware innovations, or is there as much work to be done on the hardware as there is with the software?
More work in the software, because then the hardware would be just an adaptation. It's just our understanding, or also in matching different specialties, activation of the brain, and so what is all the world of functional MRI with all these trying to find the best target.
So you mean it's kind of okay, so it's more like a scientific question. How does the brain? We need to understand kind of how the brain works. If
Right.
we want to deliver.
Right.
So we'll definitely have it solved within the next 300 years.
I was going to say, if we have to wait for that,
So that's great.
But I think, so individualization of so I think in the end, I would agree with you, that we'll have technology that'll drive individualization of the therapeutic use and also combine across different stimulation therapies. Combination of invasive and non-invasive, and I just think we're very early in a lot of exciting advances on the forefront with all of this. For sure,
and and also, I guess there's so many different targets, and as you say, there's why wouldn't 2 targets be better than 1? Maybe there's and so the complexity just becomes bewildering, doesn't it, when you think of the number of places that you could kind of relocate your stimulator and the number of different parameter settings and stuff. I had a chat with a Boston Scientific engineer the other day about their vanilla DBS system, if I can call it that, and even that has 250 million different possible settings. So the chances of finding the optimal ones for any given patient seem
right. And settings matter. I think we always just call attention to dosing parameters, because if you look at reviews of studies, some studies use 1 session, some use 5, everybody uses different intensities, and all of that probably matters. I mean, if you made an analogy to medicine, if somebody took 1 pill, somebody took 5 pills, somebody took 1 dose, and then you try to analyze the effect of that 1 drug across all these studies. So, the dosing parameters matter tremendously, just even with our standard first entry, so we can understand.
Yeah, well, a lot of interesting work to be done in the future, and no doubt you guys will be instrumental in doing much of that work. So we'll look forward to seeing and following your work in the future. So yeah, I'm afraid we've reached the end of our allotted 30 minutes, but it's been a pleasure, Giuseppina and Leigh, to speak to you both. And like I said,
and for just bringing attention to all these great topics that you're covering. So we really appreciate the opportunity to speak with you.
Brilliant. Thank you very much.